welcome back from break. It's great to see such a good group, and I'm so excited for this session. How many of you have learned something already today? There you go. Great. To set the expectations, this is an advanced session for employers that are more experienced, that are literally willing to roll up your sleeves today and dive in. We're not going to talk about benefit design, incentive strategies, or your employee education program. You already understand those tools. Instead, over the next 55 minutes, we're going to focus on behavior change and how you can influence behavior when comfortable is easy, status quo is easy. Or conversely, if influencing change is countered with active resistance to what you're trying to influence. Most of you probably have great benefit designs in place. You offer incentives, and I'm confident you have nailed your employee education program. But I would also assume you have employees that may not be making the changes you were hoping for. They're not seeing lower cost, high value care that you've been talking about, and the care that would save both your organization and them money. So, as Jonah mentioned, when that's happening, what comes next? Our default solution is often more communication, a few more nudges, a few more incentives, definitely an extra flyer. And that can be great to a point, but behavior rarely happens when you convince people to change. Yesterday, Kurt mentioned we had a small group connect, and there's 5 generations in the workforce. By a quick show of hands, how many of you would describe your generation as one that loves being told what to do? Same response as yesterday. So how do we convince people instead? We don't want to convince people. Learn from my own lesson here. The reality is people change when the decision feels safer, it feels easier, and it feels familiar. We just heard a lot about behavior change from Dr. Jonah Berger, our keynote today. In his book, The Catalyst, he gives a great example from World War II that I want to share with you. So let's set the stage. At the time, Europe was ravaged by war. So food was in short supply. Meat on the home front was actually rationed so they could send prime cuts of meat to the soldiers that were off to battle and off to war. To help with the effort at the time, the US government launched an education and advertising campaign. This should sound familiar with pamphlets, posters, lectures about nutrition, and the benefits of eating organ meat. Homemakers listened politely and continued cooking their exact same meals the way they always had. Nothing had changed. Does this sound familiar in healthcare and what you do every day? Politely listen, and nothing changes. Once the government realized that their education and awareness efforts were doing little to change the behavior, they nailed their campaign strategy. They realized the problem wasn't the knowledge, it was the behavior, and they really needed to tackle the approach a little bit differently. So they brought in a social psychologist named Kurt Lewin. Kurt decided to tackle this a little bit differently. Instead, he asked a different question: what is stopping them? And it was that simple question, that simple change, that changed everything. He started by conducting interviews and making observations. He created a plan focused specifically on just removing those barriers. Here's what he learned. First, he learned that telling people what to do didn't work. When people are pushed to do something, they push back. We heard about that this morning. Second, people were comfortable with the status quo. They enjoyed their steaks. They didn't want to give them up. Not shocking. The third thing, the size of the ask was too big. Asking people to stop eating steak instead of eating brains or kidneys several times a week seemed like too big of a change all at once. Fourth, there was uncertainty. Homemakers didn't know how to cook the organ meats, and quite frankly, they were afraid of making a mistake. Pretty big change, and they weren't sure what they were doing. And finally, for some people, it was a matter of status. Some felt organ meat and this change was beneath them. They felt the meat was for lower income families, not for them. They understood the bigger picture. Someone should make a change, but it's not me. Someone will take care of that. Can you see how this relates to healthcare and some of the things that you ask folks to do? Employees often feel pushed when employers tell them what to do or where to get care. They want to stick with the same doctors they always had. Status quo, again, is comfortable. They resist big changes all at once. Has anyone rolled out one or too many things during open enrollment? I'm sure a few of us can feel that one. They feel uncertain about going to a new provider, and they worry that lower cost means lower quality. They're not being irrational. All of these thoughts are not odd to think. They're being human. And that's what this session is about and why we're focused on behavior change and why it matters to focus on the human side of what we're doing. So back to our story. Lewin knew once the barriers came up that he needed to come up with a new plan. He understood the barriers. How do I move forward? First, he reduced the uncertainty. And in this case, what does that look like? He made organ meat easier to find at the grocery store and provided cooking tips and recipes where the meats were sold. So went to the point of action. In healthcare, this equates to providing care navigation tools or making finding a doctor easier for information about the provider. Tell them about who they're going to get their care from so people know what to expect. Second, Lewin reduced the size of the ask by encouraging people to try organ meat not just several times a week, just try it occasionally. He suggested they incorporate it into familiar dishes like filler for meatloaf or sausage. In healthcare terms, what does this mean? How do we transfer this over? How about we ask employees to try one new provider for one service and not change everything all at once? Pay attention to how big the ask is. Third, Lewin reduced the attachment to status quo. Instead of just saying organ meat is good, trust me, it's good. He showed how sticking to old habits at home was actually hurting the troops abroad. One of the questions from the audience during our keynote was exactly that. How do I connect it to the bigger picture? This is a great connection there. In healthcare, this means helping employees see how much staying with the same way of purchasing healthcare, staying with status quo, is quietly costing them. What is the bigger picture? And doing that without blaming or shaming them. And finally, Lewin stopped lecturing. He replaced expert talks with small group discussions. He asked the homemakers for their opinions on, help me out here, how do I overcome the obstacles of cooking the organ meat? Yes, it feels weird to say organ meat on this stage right now, but hearing how their peers solved similar problems truly provided the evidence that they needed, though. It even normalized the conversation, it normalized the ask, and just helped change the desired behavior overall. In healthcare terms, if you rely only on presentations, emails, open enrollment meetings, employees may feel pushed. If you rely on that one more flyer, they might feel pushed and resistant to change. But if you set up open office hours and allow them to ask questions when they have it, real time when they're navigating that decision, or allow for employees to have discussions at meetings, you're normalizing the conversation. They get to hear how peers navigated a provider change, how things have worked out for them, how they've handled the exact same concern. This is when you build momentum, and this is when behavior starts to change. So on that note, instead of me continuing to stand up here and talk at you, lecture style, let's start by, I'd like to actually invite an employer on stage and hear from someone how he navigated all of the different topics that we're talking about and changed his approach to influencing behavior within his organization. Please join me in welcoming Jake Nolan from Rice Lake Weighing Systems to the stage. Jake, thank you so much for joining us. We're grateful to have you here today. Let's start by sharing a little bit about your background. You're the Vice President of Human Resources at Rice Lake. Tell us a little bit about your organization, what your company does, and number of employees, et cetera.
Sure. Rice Lake Weighing Systems is a family-owned and operated manufacturing company based in Rice Lake, Wisconsin. We're celebrating 80 years in business this year, and I've been there about 15 years, and when I started, we had about 500 global employees, and now we have over 1,500.
Awesome. Earlier today, you mentioned 15 years, almost on the dot, so happy anniversary. Tell us your story. Your employees were tied to using their long-term high-cost providers in a fully insured plan when you first joined. They were really comfortable with the status quo and potentially overvalued what they had. Share more.
Yeah, some of you have heard the story before, but it bears repeating. When I started in 2011, Rice Lake Weighing Systems had fully insured plans. I'd been in benefits my entire career and never had a fully insured plan, so it was new learning. I'd always been involved in self-insured plans, and I pitched that to our ownership about a year into my tenure, and it was too much too fast. And so we waited until we had a crisis, and that crisis was 2015. We had a catastrophic year. We were facing a 49% renewal, and obviously unsustainable. And so then they came back to me and said, "What was that plan you had?" And so we took 2016 to put all the pieces into place. We started our clinic. We wrote the document for our Take Control of Your Health plan, and put all the pieces in place for 2017.
Sure. How did you realize that status quo wasn't, sticking with status quo was not going to be sustainable and was the problem? Did it show up in your data? Was it the renewal increase? Help us understand what prompted that.
Yeah, and just looking back at how the employees had been impacted and how the business had been impacted. Obviously, if you're a finance person or work in HR, you see the double-digit increases every year at your renewal, and that's not sustainable. And then I was looking from an HR perspective at what it was doing to our employees. The wage erosion when their health care contributions were rising faster than their pay. And it was just, like I said, unsustainable. We had to do something.
Sure. After you started your new plan, how did you realize that pushing your employees wasn't necessarily changing the behavior?
Yeah. Well, that was a learning experience. We had, going into before 2017, so in the fall of 2016, in our open enrollment meetings, we had a lot of change, right? And we were asking people to change their primary care provider if they wanted to. So according to Dr. Berger, it was good because we gave them a choice. We didn't say you had to, but you could. And then using care navigation, another thing, they were used to going to HR for advice on what they should do with healthcare, and now having a third party, somebody who is an expert and dealt in it all day, every day, that was another change for them. And another positive change was the ability in our plan design for them to receive services from our clinic at no cost to them. They could receive bundled services at no cost to them. They could make a choice between what tier they wanted to see providers in, and so it impacted their deductible and their co-insurance. And so again, listening to Dr. Berger, I see a lot of things that we did right, and I see a lot of things that we could improve upon.
Sure, that's such a great connection. What specific barriers did you notice that were keeping the employees from trying something new?
Again, I chuckled when he was talking about the status quo, and I said comfort zone. And people had been with their primary care providers in some cases for decades. And those primary care providers were entrenched in large healthcare systems. And to try and show people the value of changing to another provider, it's a very personal thing. And that personal relationship usually outweighed the financial impact of, well, you have to, you pay this if you go there versus no cost to you if you go to our new clinic. And so that took some time to get people to try it, and I will say overwhelmingly, it has been a huge success. People have claimed that if our providers leave, that they're going to leave, and so they become very attached.
That is a new one. How many of you have heard that before? It's a great testament to the work you've done. What were employees unsure or nervous about specifically? And I would add on to that, how did you recognize those barriers or what they were nervous about?
It was the pushback, right? When we said we're going to do this, we would have people, because we did the traditional mandatory meetings where people would come and for enrollment meetings, and we say we're going to do this, and then there are those people, and you know them, right? They're the people that are always going to speak up. They're always going to make a statement for everybody else in the meeting about what is, but it's really those things that concern them. And so when those vocal people would voice a concern, we made sure that we had an answer, or at least got an answer for them. And so dealing with some of that pushback. But again, selling value is huge. What does it mean for you? What does it mean for your family? And once we got past that, the first year where it was new, we literally, our clinic is not on site, it's near site, it's a whole mile away. But we literally drew maps for people, right? We had maps on our bulletin boards. We would show them exactly where it was, so getting there wasn't scary. And then once they had that experience, those people who went, the early adopters, they were our best marketers, because they would come back and they would tell everybody that they could about what a great experience they had. So.
That's awesome. That's a great example of how you made it seem easier, made this change feel smaller. Are there any other examples of how you just made the path easier for employees?
Yeah, I would look to our partners, and the Alliance has been a great partner for making things easier. Find a Doc makes it easier. Having care navigators makes it easier. Imagine if you come out of an appointment and you need a referral, right, for colonoscopy, mammogram, whatever it is, and you come out and there's somebody at the desk sitting there that the provider has already come and seen them and said, hey, this person needs this procedure. And they look it up, and they're waiting for them to come out of the exam room, and they say, I understand, and here are your choices. Which one do you want, right? And to have that right there, especially for something that somebody doesn't want to do, like a colonoscopy, right? But if they make that choice, and then they get it scheduled, they're much more likely to do it than if they escape, right? Salespeople, never let them leave, right? Make sure you get the order. But the same thing with patients. Make sure that they get the appointment, get it set up, then they're much more likely to go and get the care that they need.
Sure. You mentioned the transition, and one thing we've talked about in the past is giving them a year to adapt. Were there specific things in that transition year? We have many folks in this audience that are looking to implement change. What did you focus on in that first year of adaptation, if you will?
Yeah. One thing that was big for us and our ownership was no takeaways. And so in our plan design, if they wanted to continue doing what they had done in the past, they could do so with the same deductible, same coinsurance, and same contribution to the plan. And what we were doing, right, and that was in what we call Tier 3, we were selling the value of Tier 2 and Tier 1 to them. Right. Obviously, there's a value to the plan when they're choosing high-value providers, that we have through the Alliance when they're choosing to go to our clinic for primary care instead of going to a large health system. Really just allowing them to have choice, and then seeing the value of it as they went through, and then creating a new comfort zone in these, this new structure that we provided.
Sure, awesome. You mentioned that some of the early adopters became the biggest advocates for change. Did peer conversations or employee discussions help? And how did that play out?
Yeah, I mentioned the early adopters being key to the success of it, but I would also say that our leadership team, our president and owner, he uses the clinic, and so does his family. And so, knowing that our executives were using it, and really walking the talk, and understanding that there wasn't a two-tier system. There wasn't this thing for all the employees and then this thing for the executives. It was all the same for everybody, whether you worked in the shop or the office or wherever you were.
Sure. That is great. Leadership engaging in the program is so important and impactful. By sharing financial cost with the employees, by sharing the financial cost in the big picture, were employees able to persuade themselves that change was in their best interest? And if so, how long are we talking here? How long did it take?
We saw almost immediate benefit to our health plan. Again, we were facing this horrific renewal on our fully insured plan, so we had a huge drop off in our overall costs in that first year. And that allowed us to not have any increase to employee contributions in the next year. We're like, hey, this is working, let's share in it with the employees. And then it happened again the next year, and the next year, and the next year. And I'm proud to say that for 11 years in a row, we have not had an employee contribution increase. Thank you. $20 a week, that's the employee contribution. Our lowest deductible is $500 with 10% coinsurance in Tier 2. And in Tier 3, it is $750 deductible with 20% coinsurance, which is where we started 11 years ago, and it's still there today.
That's amazing. By show of hands, how many of you can report those same stats out on increase? And that is similar to what I expected with the generational question. Doing something and trying something one step at a time does matter. Tackling the barriers one by one is why we're here today. So hopefully there's some examples. So what's next from what you've learned in the past? What are you preparing for in the future?
We'll have a little bit of a cautionary tale. I thought 2015 was bad. 2025 was worse. I've been in benefits. I started as a benefit analyst at Fortune Brands in 1994. I've been in and around it my entire career. Again, mostly self-insured. I had always had aggregate coverage. I've never had an aggregate claim in my entire career, and I had my first last year. It was a perfect storm with not one, not two, but 3 transplants, 7 or 8 very intensive cancer patients. We had a catastrophic home accident. It just was incredible. And we had the unfortunate situation of a member getting into a rehab clinic in California. That was $3,000 a day. And all those things added up, right? And it's the reason why we have reinsurance, and kind of the bane of my existence. If you've heard me speak before, I don't speak very kindly of the reinsurers, but glad that we had it last year. But really the point that I wanted to make is we need to prepare for a world where it seems like we're getting sicker, right? That we have more claims, that we have more high-cost claims, and we've done a fantastic job with primary care. We have done a tremendous job with creating the bundled contracts for those non-emergent schedulable procedures. that all of us become so familiar with, right? And all the things that we've done there. The next big thing that I see is how can we get people the care that they need with some form of cost containment for those catastrophic situations where we are hitting our specific deductible, and maybe if you're unfortunate enough, your aggregate deductible. That's kind of the next big thing that I would like to tackle. But for me, it is, I don't have any magic wand. I am not any super genius. I'm not a professor. Everything that I know, I learned from people like the people in this room. Everything that I know, I pretty much stole from somebody else and made it work for my organization. And that's my plan for the next 3 to 5 years is how can we tackle this issue of the catastrophic illnesses and the high-cost claims. It's hard to say.
That was a rough year. Thank you for sharing that example. I think what it brings us all back to is why the importance of any step forward is why we're here. We need to make a change. It does matter. Part of being an employer with the Alliance and the cooperative is exactly what Jake said, learning from each other. We do not have to make the same mistakes or make the small same steps. Let's learn from each other throughout this whole process. At the Alliance on our own plan, if you've been on our webinars recently, we've been trying to incorporate our own lessons. We do talk about this every day. But we weren't exempt from, hey, maybe that one doesn't apply to me, or do I actually know where to go to get that? So even one small step that we've taken internally is, one, sharing on the webinars on a much broader scale, but even at our all-staff meetings, just sharing some of the examples of how we've accessed things differently. It helps you in this room, but also helps all of us learn and understand the barriers from a different angle. So the employee discussions have really kind of evolved. As we wrap up this conversation, if you think back to our World War II story, change didn't happen because the government pushed harder. It happened because they made change easier. And that is why shifting the focus to removing barriers, making things easy, and ultimately truly understanding what the barriers are. I am guilty of this, so I'll throw it out there. How many of you have assumed you know what the barriers are and exactly what the solutions are in our industry? As we kicked off, I think Kurt said it as well as Dr. Berger, we all have many ideas on what the solution is. But when was the last time you paused and asked and pulled all of the themes together to make sure that you really are tackling the right barriers and prioritizing them? What you just heard relates to the world of self-funding. So Jake's organization hasn't forced change. They removed barriers, made it easier for employees, and allowed employees to persuade themselves to try something new. At this time, I'd like to open up the session to get questions from our audience. So if you have questions for myself or Jake, please send them in via the app or go ahead and step up to the mic. The session is being recorded, as we mentioned, so it's important that you use your mic to get the questions on file for everyone.
Hi, Jake and Melanie. Thank you for being here, and thank you for sharing your story, Jake. One of the things that you said really kind of stopped me and really kind of made me start thinking hard about the 11 years in a row with no employee contribution increase. When we're in situations where we can see the cost increases happening in our claims, and we're hearing from our brokers like 9% is standard, this is the trend, this is what we're seeing. So let's start at 9 and let's go from there. What do you attribute to your success of containing? Because I mean, ultimately over 11 years, you had to be decreasing your exposure in order to stay flat, not just holding costs because the prices were going up. Are there any particular areas where you saw Rice Lake winning?
Yeah, I would say that our direct primary care clinic run by Neopath Health it is the center of our health plan. It is what makes it tick, not just for primary care, but also for referrals out, getting people into high-value providers, and making sure that they understand their options through care navigation. So that's one thing. I say constant communication, but effective communication with our members. And yes, I am prone to too many email bursts, but I've reined it in, and I try to cover just one topic at a time. I do reminders that we have these things with my HR staff, training them to be subject matter experts in our plan, so they are a daily resource for all of our employees that they can call, they can email, they can set up an appointment, and they all know our plans to help, again, with steerage and what their options are. So all the things that we're doing together, and just to create better healthcare consumers, but still make sure that we're taking care of our employees. When we first started, people were wondering with these with the bundles, and when I show up at Marshfield Clinic, I know what I'm going to get. When I go over to Eau Claire, or I go to Hudson, to a new place, I don't know exactly what I'm going to get. But thankfully, they come back reporting, no, it wasn't in a back alley. No, the surgical supplies were sterile, and it was a good experience. But all of that, taken together, how can we do it for 11 years? And really, it's consumerism and reminding and creating new options, creating more bundles, creating new partners, doing those things. How can we do it in the face of, the year that we had last year? And we didn't increase, and we knew what last year looked like. But a $2 million excess net, but we had saved well in excess of $25 million over the last 10 years. It was, in our ownership's mind, it was, no, this is not the time to do the increase, because they've been doing all the hard work all these years. We had a bad year. We're going to sustain, and then we're going to re-engage, and we're going to kick in and try to do things. And really, it's the analysis, it's those large claims that has me so focused on what I'm going to focus on for the next few years.
That's great. Thank you.
Tacking onto that question and using your former benefit analyst days, one of the questions that was sent in beforehand was about metrics. So what metrics should employers look at first to solve this? And are there any in particular that they can pay attention to know if behavior change is happening?
Yeah, a huge one for us is clinic utilization, and we've been as high as 95. We'd like to be around 85, which is manageable for the staff and allows for some acute care, walk-in, those kinds of things. So clinic utilization is a huge thing, but also the overall all rolled up cost of how much it all comes in, that's the main driver that we're looking at. And that we're making decisions off of.
Great. Are there any other questions from the audience?
We're getting a lot of questions in the app, so I'll ask a couple.
Great.
Are you able to share the cost of running an on-site clinic, or if not actual cost, percentage of healthcare cost?
Sure. Ballpark figure when we started was about $1,000 per employee member per year. And now it's about $1,000 per member per year. So you do the math, 2.2. But again, somewhere around $1,500 per employee member per year now.
Are you willing to share how and or what information you provide to your executive team to help them gain ownership and understanding of the healthcare challenges and opportunities?
We have a procedure that we follow, and before we do the open enrollment meetings, we take our executive team through that, let them punch holes in it, ask any questions, make sure that they understand before we present it to the workforce what is going to happen and how they can help us in the communication, debunking any erroneous thoughts or maybe opinions. So really try to get them engaged from the beginning.
So a pre-open enrollment workshop session with your executives. It's great.
Do you have a clinical navigation solution in place for your members?
Yes, we had, originally we were one of the pilot companies, organizations with Alethius, and a few years ago we made a change and brought that in-house. And so now our partners at Neopath Health, who run our clinic, they also provide the care navigation services, and that has worked very well.
Can you share a bit about how you encourage prevention with your employees? For example, treating obesity or keeping folks in control with their A1C to control those downstream expenses.
Yeah. I wish I could take credit for the name of our health plan. It is the Take Control of Your Health plan, right? And for the employees, it is Take Control of Your Health. And that's what our ownership wanted, the message he wanted to deliver to our employees, take control of your health. For me and my team and everybody in this room, you want to take control of your health plan. So I like the nuance there. I like the
I'm
double
sold.
entendre.
You can take credit or not. Feel free to take it in the audience, is what I heard earlier.
But really, that ownership and understanding that, again, starting with primary care, getting the care that you need when you need it, age-appropriate exams, all those kinds of things. We do have a wellness incentive. We have tried to have outcomes-related incentives for the wellness plan, and it was a lot of work, and it didn't really move the needle. We have shifted back to participation. We want you to have a physical at least once a year or a wellness exam. We hope that they do it in our clinic, but we allow it to be done outside of our clinic for our remote employees or for people who, the very small minority who don't use our clinic. But again, what can you do to take control of your health? And again, removing barriers, because there is no cost for any procedure at our clinic, and they do much more than primary care. The list is long, and it grows every year.
Great.
What
There you go. Go ahead.
What is your recommendation to employers who have 5 major health systems in their area, with locations on every corner funneling employees through them?
Move. No. Wow. And that takes me back to where we were in northern Wisconsin. We were at the front lines between Marshfield Clinic and Mayo Clinic, and we had Marshfield Clinic Regional Hospital in Rice Lake, and we had a Mayo Clinic Hospital in Barron, just 10 miles away, and a population in our county of 40,000 and 10,000 in Rice Lake, and we have these 2 hospitals plus a Mayo Clinic in Rice Lake. And the interesting thing in the Wayback Machine, when we were fully insured, they told us that Barron County had the highest cost of health care in the country per capita. And I believe that is why. And they weren't competing, and most everybody was, and back in the olden days, was fully insured. So, and they had no need to. But in the question, what do you do about competition? It is something that I struggle with, and the way I describe it is you can't invite everybody to the dance, right? You have to choose who your partners are. And then you have to provide some benefit to them to be your partner, right? And for us, when we have, I'll use direct contracting as an example, in the early days, when we started our own private direct contract with a physical therapy group in Rice Lake, we said, okay, we agree on the pricing, and here's what you get. And what you get is, basically you get all of our utilization, and still people had choice, but we're going to funnel people to you, and that's the benefit to you. You're going to get volume, we get reduced price. That's a win-win as partners. Much harder to do if you're battling 5 different health systems in in the community where you operate, but you need to choose some partners, and then you need to make it a benefit for them as well.
I think one thing I'd add there is assuming that focus on the human behind the decision. So assuming that people are going to change, there's 5 systems right in front of them. So what is easy? Give them the information, help them know that there are options. We're trained to use the system a certain way today. So start with something, but focus on the person making that decision, the behavior change, and not necessarily from the system on.
Yeah, I would add one more thing to that, and that is some of you who've I've spoken with before, you've seen me speak before, you've heard the very hard decision that we made to carve out Mayo Clinic Health Systems, and it was an unsustainable partnership, and they weren't willing to do the things that Marshfield Clinic was. Obviously, Marshfield Clinic now is in the Premier Ruby network with the Alliance. And it was really hard, and we gave people a year's notice. This is what's going to happen. We allowed for the change, but we said it has to happen for the health of our health plan. And so making those hard choices and choosing partners is really important.
One of the questions that came through in advance was specifically related to trust. It is so important. You've illustrated why change is so important. You've mentioned advance notice, giving people advance notice, having support from the top down. What are other ways that you build employee trust so that they're willing to hear you to the next part of the discussion and change behavior?
Yeah, that's going to sound cliche, but do what you say you're going to do. If somebody goes and they go through care navigation and they're expecting this procedure to be no cost to them, and then there's some hiccup in the system or whatever, we've had to eat some claims that weren't directed perfectly in the early days, and things that you don't know about when a provider for a colonoscopy redirects them to a hospital because the patient's BMI. Who knows these things until you experience it for the first time? And I certainly didn't know those things, but we still covered it, and because the member or the employee was trying to do the right thing, so that garners trust.
Great. Knowing what you know now, and we have folks in the room at every end of this journey, if they could choose just one thing to steer or guide, where would you start? I would say learn from people who've been there before. There's a lot of people in this room that I stole shamelessly from, and I would encourage you to do so. I have very willingly given away our plan design, everything that we've done, our structure for more than a decade now. It's worked for us. If you take that and tweak it, make it work for your organization, it's a good place to start. And don't try to do it all alone, and don't reinvent the wheel, because there's been a lot of thought put into what has happened already. But we need more leaders, right? It's pretty easy to hop on the coattails of those who have come before you and have some success, but we need the next generation to step up, the people who are going to be the tip of the spear for the next 10 years. And perfect. So not everyone in this room will have an on-site or near-site clinic. However, there are other options. There's DPCs, and really starting with primary care is where we've seen a lot of traction. That is where the care is steered from in many cases. So teaching people about that front-end intake, what to expect, what are your options. Again, not to push towards any direction, but just understand, here are the different options and the benefits. What was the number that Jonah threw out? Even if it's 2.6 times better for you, we may be hesitant to make that change. So it's not just the facts, but understand the options. And as we go into the next sessions today or even wrap up right now, ask peers about what they're doing, learn from each other in these different situations. All right, let me see if I have another question. Were there any more on the app? The voice of
Yes.
the God, I'm trying to not speak over.
Yes. What would you say is the best way you're able to communicate STEER to your on-site clinic?
Best way to steer to our on-site clinic. Again, I think I started out saying it's the people and the early adopters and their experience and what they had. Reminding people when they come to you and say, what should I do? Make sure that our near-site clinic is one of the first things, the first point of contact. Let them do the referring, let them do the diagnosis, and we've had as high as 95% utilization of our clinic historically. So just being there, communicating, reminding people. I learned something this morning, so I'm going to go back and rethink how we're doing these things. But removing those barriers, and I think we do a good job at all those things, and I think it's a reason why it's successful.
Sure. Great. Is there another question from the app?
Nope, we're all good. Thank you.
Perfect. Thanks. This is about all that we have time for today from a question perspective. Thank you so much for sharing your experience and your insights. The stats speak for themselves, but there's a question. Go for it.
Cutting out a major hospital system is something that we talk about often with clients, and it's a really uncomfortable topic to go through, but it's a reality for a lot of groups. When you cut out the Mayo system, can you just talk about any employee fallout or maybe a little more about the communication, and then if there was any repercussions from losing employees because of it?
Yeah.
Great question.
So when we made the final decision, and we talked about it for a couple of years before we actually pulled the trigger, and the first resistance to it was our owner saying, well, I want to go to Mayo, right? It's the best healthcare in the world. And I said, yeah, but Mark, it's the most expensive healthcare in the world. If we don't make a radical change, here's the impact on the plan, here's the impact to you, right? We're family owned, privately held. It's literally money coming out of his pocket. And so begrudgingly, when we had the data and we looked at what we were spending, and typically we would have something less than 5 major claims, but it was costing us $1 million, $1.5 million a year just to go to Mayo, right, for the brand name for that. And carving that out of our plan, I felt was our fiduciary duty, my fiduciary duty. I'm the plan administrator, and so we did. And when the year before, so it was really more like 15 months, because we announced it during open enrollment. We said, okay, you'll have all of the next plan year to make your changes. If you are starting treatment, we recommend that you don't start treatment, because we are going to end. It will be out of network at the end of the next year. We had some hangers on. We had people who moved up knee replacements to have it done, because they had the other one done at Mayo and they wanted to get it quick there, because $70,000 versus the $23,000 one we were offering. But they would do that. But I think we did it the right way. We still had some people who were upset because we had moved from Mayo to Marshfield and back to Mayo, and now we're going back again. But having given them enough time and given them the background and the reason why we're doing it was unsustainable. They may not have liked it, but in the end, they accepted it. But I still, to this day, we haven't had Mayo in our plan since 2019. We still have people going out of network by choice. So for this year, we changed our out-of-pocket maximum to $50,000. because there wasn't enough in it for them to, disincentive.
Sure.
So we'll see if that works.
All right. Any final questions before we close out our session?
What percentage of employees, spouses, and children used the Nearsight Clinic last year?
Last year, I believe we were down a little bit. I think the end was 87% of our Wisconsin population used our clinic at least once.
Great. That's about all that we have time for. Jake, thank you so much for sharing your experience, your knowledge, the great examples, and for being open to discussion after. If anyone wants to ask questions one-on-one, please join me in thanking Jake for his time.